Okay, now we're going to jump over to the chapter with the first perfusion. We're going to go through this, and then I'm going to come back, and we'll talk about things that I think are important. So as we know, perfusion is the flow of blood through arteries and capillaries that deliver nutrients and oxygen to cells. One thing that can happen with perfusion problem, it could be like chest pain. And this is caused by ischemia, and we know ischemia is reduced blood flow. And a name for this is angina pectoris. And if you have prolonged ischemia, prolonged angina pectoris, that'll lead to a myocardial infarction, which means that myocardial tissue has died and it will not regenerate. Talking about central perfusion, this is generated all by our cardiac output. It's basically the amount of blood pumped by the heart each minute. So central perfusion of blood begins when the heart is stimulated by electrical impulse. It gets a little jolt that usually originates in the SA node. This then goes to the AV node, and then it goes, then from the AV node, the impulse moves through a series of branches that hit the bundle of His and Purkinje fibers in the myocardium, which causes the ventricles to contract, which is what is called what? Systole. Duh. So there are two variables that contribute to cardiac output. They are stroke volume and heart rate. It's just some things that we got to know. Tissue perfusion. Tissue perfusion is the volume of blood that flows through target organs. So what would you say the pressure that tissue perfusion creates is called? Cardiac hydrostatic pressure, and that pushes blood through capillaries into special spaces, allowing delivery of oxygen, fluids, and nutrients. So, what do you think arterioles do for tissue perfusion? They maintain blood pressure by constricting or dilating responsive stimuli. And then what do you think the venules do for tissue perfusion? They act as a reservoir for extra blood to decrease the work on the heart if they need them. So we know there are age-related distances in the heart. In infants, the size of the heart to the total body is larger. We also know systolic blood pressure at birth is lower because we have a weaker left ventricle. However, the left side of the heart develops strength, and the systolic pressure rises sharply during the first 6 weeks. Pretty cool. And then older adults, we have a bunch of cardiovascular changes with age. Stiffening of the arteries contributes to an increase in blood pressure, which increases the workload of the myocardium. You know that. So we know that there can be impaired central perfusion. That's like when we have reduced cardiac output, because we know central perfusion is dealing with cardiac output. So we can have inefficient mechanisms within the heart can occur from changes in the myocardial conduction, problems with the heart valves, disease of the heart muscle tissue, and congenital defects. Central perfusion problems result in increased stroke volume resistance attributed to vasoconstriction of the artery or increased viscosity of the blood, which an increased SVR requires the heart to increase contractile force and or increase heart rate to maintain adequate cardiac output. But we know the heart has limits to the compensatory effect. A sustained increase in SVR eventually leads to insufficient central perfusion. Likewise, cardiac output is affected by a reduction in SVR attributed to vasodilation of the arteries or blood loss. Along with impaired central perfusion, we also have impaired local or tissue perfusion, and it just depends on what's causing it. So like different organs and tissues require different volumes of blood to maintain adequate functions. So the brain and intestines, they need large volumes of perfused blood compared to the skeletal muscle, and inadequate tissue perfusion can result from poor central perfusion or from a mechanism within the organ itself, such as a blocked blood vessel leading to or from tissue, or from excessive edema within the tissue interfering with the cellular oxygen exchange, or increased pressure and associated constriction of collapse of arteries, stuff like that. So along with these being impaired, obviously if something's impaired, you're going to have something that happens over the long run. So it can lead to decreased cardiac output or cause shock if you have impaired central perfusion. Cardiac output is decreased when there is inadequate perfusion to the myocardium, inadequate impulse conduction through the heart, or malfunction of a heart valve. Any occlusion or constriction of coronary arteries that reduces blood flow to the myocardium can result in an MI, decreases cardiac output. This impairment prevents the myocardium from performing the mechanical function of pumping blood to the body. Also, altered impulse conduction through the heart that goes from the SA to the AV to the right and left bundle branches of Purkinje fibers that interrupts the electrical function necessary for the myocardium to contract and results in disorganized contraction. Finally, malfunction of heart valves, either stenosis or insufficiency, impairs flow of blood through the heart. And then shock, which is the inability of central perfusion to supply blood to peripheral tissues, occurs when the heart is unable to act as a pump. So that's cardiogenic shock, fluid is lost, hemorrhagic shock, or the systemic vasodilation occurs in the form of anaphylactic, neurogenic, or septic shock. We also can have consequences of impaired tissue perfusion. Impairment of tissue perfusion associated with the occlusion, constriction, or dilation of arteries or veins. Atherosclerosis or thrombi, these can include arteries, and thrombi, they can include veins. Vasoconstriction can occur from frostbite as well. Examples of dilation can be like aneurysms in arteries and varicose veins. We know impaired tissue perfusion interferes with blood flow that causes ischemia to localized tissue, and if uncorrected, cell death. Ischemia is reversible cellular injury that occurs when the demand for oxygen exceeds the supply because of reduction of cessation of blood flow. This is an example of the interrelationship between the cardiovascular and respiratory systems because cells are deprived of oxygen from the lack of blood flow and from the lack of oxygen, or both. Decreased oxygen to the mitochondria reduces ATP production, which causes two things. First, oxygen is not available for the cell's usual oxidative metabolism. They are forced to use anaerobic metabolism, creating ATP from glycogen to maintain cell function. This creates lactic acid, which accumulates in the cell, causing cellular acidosis. This causes lysosomes, which are the cell's digestive organelles, to swell and eventually release acidic enzymes that auto-digest cellular structures. The destruction of tissues release enzymes such as creatine. Measures of the enzymes after a MI indicates the degree of damage to the heart tissue. The second problem, lack of ATP is unavailable to maintain ATP pumps. The sodium-potassium pumps normally use energy provided by ATP to pump sodium out of the cell and allow potassium into the cell. When ATP is unavailable, you have a deficit in potassium in the cells. This causes dysrhythmias in myocardial tissue. Also, sodium remains in the cell and draws in water, resulting in swelling within the cell, dilation of the ER, and decreased mitochondrial function, increased membrane permeability. This increased membrane permeability allows calcium ions to enter the mitochondria, where they activate lipases and proteases and increase the production of free radicals. The membrane damage initiates the inflammatory process, producing prostaglandins, thromboxanes, and cytokines. When ischemia persists, irreversible cell injury or cell death occurs from necrosis. So, with impaired perfusion, we can have individual risk factors. They can be modifiable and unmodifiable. So what do you think some modifiable risk factors would be? Well, it could be like smoking, elevated serum lipids, being sedentary, obese, having diabetes, or hypertension. What does smoking do? What could that cause? Oh, the nicotine when you smoke, that vasoconstricts. Now, what does the elevated serum lipids, how can that impair perfusion? That can contribute to atherosclerosis. How can a sedentary lifestyle impair perfusion? That can cause obesity. How can obesity impair perfusion? That increases your risk for type 2 diabetes and atherosclerosis. How can diabetes cause impaired perfusion? That can increase the risk of atherosclerosis. And how does hypertension impair perfusion? That increases your work of myocardium. So what do you think some unmodifiable risk factors would be? Age, gender, and genetics. With age, your impaired perfusion increases with age. With gender, if you're a male, you're going to have more risk for impaired perfusion than women, and then genetics, like your family history, stuff like that. So we talked about this earlier, but some ways to see that cerebral tissue perfusion indicated, we look at the patient's orientation to time, person, place, and situation. They can move and have sensations bilaterally. They have the carotid pulse, and they don't have a carotid bruit. Peripheral tissue perfusion, the extremities are going to be warm. They're going to be appropriate color for race. And then the radial and dorsal pedis pulses are between 60 to 100 beats per minute with rather rhythm, easily palpable upstroke, and smooth and routed contour. And then peripheral perfusion is indicated when the capillary fills less than 2, ABI is greater than 0.9, and they have warm hands, feet, and there is an absence of continuous pain in the fingers, toes, or legs, pain when walking. All right, now let's look at some blood diagnostic tests, okay? So creatine kinase, it's CKMB if it's in the myocardium, CKMM if it's in the muscle, CKBB is in the brain. So if we have a myocardial infarct, which CK do you think would be elevated? CKMB. Now, what is lactase dehydrogenase? When is that When is that elevated? When the myocardium and erythrocytes are damaged. So we have two natriuretic peptides, two hormones, A and P. This is secreted from right atrial cells when right atrial pressures increase, and that's used to detect heart failure. And then B and P, this is secreted from cardiac cells and increased. And what does this use to detect them out? It's increased heart failure too. So troponin, this is released after what? MI usually. It predicts the MI. So then we have different types of heart tests. We're going to look at cardiac stress tests. We got an exercise cardiac stress test. You get put on a treadmill and you progress in speed and elevation. So if you think coronary artery disease is present, what do you think some of the changes may happen? What do you think you'd see? Well, you'd have changes in electrical conduction or other symptoms, and you may have chest pain too.